Hi, I'm Cush with Rheumnow. I'm here at RWCS 2019 in Wailea, Maui. Great meeting, great faculty. We just had our first morning. We led off the meeting, Artie Kavanaugh and myself, with an update in RA, what we thought was exciting or interesting from recent meetings and what was published in the last year. I'm going to cover three things, that being prednisone, seropositivity, and cardiovascular issues. The first, prednisone. The SAMIRA study, authored by Gerd Burmester and Frank Bukarek, looked at the value of being on continuous low-dose prednisone. These are RA patients who are on conventional or biologic DMARDs, and they're either on 5 milligrams of prednisone and they're in remission, and they continue half the group on the 5 milligrams of prednisone, and the other half, they have a tapered withdrawal of steroid. And they look at the outcomes after 24 weeks. Well, there's positives and negatives to this. Clearly, patients who stayed on the 5 milligrams of prednisone did better. And it's significantly better. You look at the graphs, it's like this, and it looks like, well, I should probably continue the 5 milligrams of prednisone. And the side effects and toxicities were a little bit more when you were on the prednisone versus off the prednisone, but it wasn't very significant. But remember, this is only 24 weeks. What would have happened if that was taken out for 2 years or 3 years? What was seen, however, was that 2/3 of patients who they tried to withdraw the steroids on actually did very well and were able to withdraw and stay off the steroid. When you look at, again, the continuous group, they had 14 flares. When they look at the steroid withdrawal group, they had 34 flares. So there's a price to pay in getting off steroids, but the benefit is that 2/3 of patients can get off. And then there's a long-term consequences. So again, maybe the story really has to do with the activity of the patient. The patient has really severe disease, low-dose prednisone might have to be part of your long-term regimen. On the other hand, if you're doing very well with therapy, why not try to get to no steroids in 2/3 of the patients, even risking the chance of flares in some. A really interesting paper, could spurn a lot of discussion. The second issue is seropositivity. That we presented a few different things about seropositivity. One was clearly the benefit, the hazards of the titer of CCP. The authors on this particular paper looked at low titers of CCP versus medium versus high, and these were in patients who were just CCP positive but did not yet have rheumatoid arthritis. Clearly, medium and high levels of CCP was associated with significantly increased risk of developing RA in, I think it was 1 year or 2 years. And the high titer ones were more than 50% developed rheumatoid arthritis. I think that tells you a lot, especially when considering what the seropositivity means in someone with preclinical RA not yet diagnosed. Another interesting abstract looked at the whether you go positive or negative on rheumatoid factor or CCP. This is a large study, the IMPROVE study, that looked at a lot of different therapies, a lot of different patients, and basically showed that with therapy, patients' rheumatoid factor and CCP will usually decline. So that the seropositivity is a function of how much inflammation you have. However, even though it does come down, it does not correlate with clinical measures of activity. EULAR, good responses, other types of responses, et cetera. So you really can't use as an outcome or biomarker and whatnot. And likewise, they showed that when people flared, their rheumatoid factor or CCP usually rose. So again, there's a real limitation to this seropositive issue as far as either choosing therapy or monitoring therapy, but it is an expectation of therapy. And lastly, cardiovascular issues. We showed a lot of different slides showing what you all know. Methotrexate clearly reduces cardiovascular risk, cardiovascular death. TNF inhibitors and other biologics further add to that reduction, and that's all well and good. The question is, with those great therapies, especially methotrexate or biologics, can that be applied to patients who don't have rheumatoid arthritis, patients at high risk for cardiovascular endpoints like MI and stroke and whatnot? So these are patients who, cardiac patients, no arthritis, and two major studies we reviewed. One was the CANTOS study and the second was the CERT study. CANTOS was a study of canakinumab, the IL-1 inhibitor, where patients who were at cardiovascular high risk were enrolled and they had to have a high CRP going in. The CANTOS study was great. It showed that there was a significant reduction in cardiovascular events and cardiovascular deaths, but there was these additional things that were really astounding. There was less gout attacks in people that were on chronic IL-1. There was less need for orthopedic and hip and knee surgery and joint replacement. And lastly, there was less cancer, especially lung cancer, in the patients who were taking the IL-1 inhibitor. However, the real study everybody was waiting for was the CERT study. Both of these were authored by Paul Ritger out of Harvard. The CERT study looked at methotrexate as the intervention. The studies were roughly the same in their design, who got in, what the endpoints were, but the CERT study, the methotrexate study, did not require a high CRP going in. And as such, that study failed. It was actually prematurely halted. They had equal number of cardiovascular endpoints with either those are on placebo or those are on methotrexate. And that study has basically killed the idea of control of inflammation in cardiovascular patients at high risk outside the arthritis clinic. We will continue to use these therapies in our rheumatology clinics, but amongst cardiologists, the talk is that didn't really work. And oh, by the way, the CANTO study, which was so successful, went in front of the FDA and was denied by the FDA to have cardiovascular risk as an indication for the use of the IL-1 inhibitor. Now they're negotiating and maybe that'll come out differently in the future, but it doesn't look good for treating inflammation to manage the inflammatory component that goes along with cardiovascular disease. We certainly know in RA there's an inflammatory component. We're managing it in a sort of bystander way and using it as a way to push therapy. So anyway, this was just a small sampling. Artie will give you the rest. Check out the videos for RWCS on Rheumnow and rwcs.com.